The following program is a Town of Colonie television production of the William K. Sanford Town Library.
So, in terms of our topic for today, as our nation becomes grayer, palliative care and hospice are playing an increasingly important role in American medicine. Many of us have experienced the services of palliative care and hospice for aging relatives, and some of us realize that we may need to be thinking about that ourselves sometime in the future, hopefully a distant future. We are very privileged today to have Dr. David Pratt with us to talk about hospice and palliative care. And if you are a member of Compassion and Choices and you receive this magazine, or if you'd like a copy, they are in the back. You'll see that David was featured in the magazine with a beautiful picture and an article about the wonderful work he is doing to support medical aid in dying. Dr. Pratt is a board-certified internist with a subspecialty certification in pulmonary medicine and preventive medicine. He has a medical degree from Tufts University and a master's degree in public health from the University of Albany. He was the Commissioner of Public Health Services for Schenectady County from 2009 to 2012, and currently he is a private consultant in public health, palliative care, and preventive medicine. And Dr. Pratt is the co-author of more than 50 peer-reviewed healthcare publications and is currently a member of the board of directors for MVP Health Plan. And as I said earlier, he has been a very active proponent of medical aid in dying and just recently gave a TED Talk right here in Albany. So that's pretty impressive. And we are very proud and privileged to have him here today to speak to us. Dr. Pratt.
Thank you, Bonnie. I can assure you my battery's not running low. So maybe their battery is running low. So it's an honor, it's a privilege and honor to be here with Death with Dignity-Albany. I've been in the audience for a number of the presentations. Let me just check, can everybody hear me? Am I doing okay with the sound? A little bit more? Okay, I'll speak up.
You really have to project into that mic.
Okay. So I'll do my best here to project into the microphone. Today's presentation actually came about from a luncheon on a very sunny afternoon with Bonnie and me in Albany, and we were discussing a variety of issues, not so much medical aid in dying, but the whole toolkit that doctors and others have that can help individuals at the end of their lives. So she said, well, I mean, there were a number of points that I made that were somewhat surprising to Bonnie. And she said, I just think that audiences like this one would find it interesting to hear a little bit about the background about palliative care, hospice care, and so on and so forth. So this is kind of where the flight is going. You know how in an aircraft they tell you this flight is going? Well, this is where today's flight is going. We're going to talk about these items, palliative care. We're going to give a definition. We're going to talk about demography and the impact demography has on the topic area. A little bit of a history. Then a U.S. clinician's view, the efficacy of palliative care and hospice, the clinician's view, what does it look like from the clinician's side, the benefit itself, what are the trends, individuals' actions that we can all take in aiding ourselves at the end of life, and then finally a little bit of a summary. And I'm going to watch you. If there are places, pardon me, in this that you want to stop and have a more lengthy discussion, we can do that. Otherwise, we'll kind of click along and provide the information. These areas with palliative care, hospice, end of life, medical aid in dying, death with dignity are difficult. As you all know, from personal experience, no doubt, and social experience. I remember what Woody Allen said all about this. He said, I am not afraid of dying. It's just I don't want to be there when it happens. And I think probably we all feel that way. To know what we're all talking about, to make sure we're all in the same place of the hymnal here, palliative care is an approach that improves the quality of life of patients and their families. Very important that palliative care plays a family role as well as the patient role. And this is from the WHO, the World Health Organization definition. Facing problems associated with life-threatening or so-called life-limiting illnesses through the prevention and the relief of suffering. Okay. Very low, 7%. Okay. Through the identification and impeccable, I love this, impeccable assessment of treatment and pain and the problems physical, psychosocial, and spiritual. So that's the WHO definition of what palliative care is all about. It's, in many ways, it's very expansive, but I think you'll hear that in practice, many times we really try to achieve those things and do achieve those things. People often want to know what's the difference, what is the connection, how does palliative care, how does hospice work together? And the easiest way to think about it is that all of hospice includes all of hospice is palliative care, but not all of palliative care is hospice, which means that hospice resides in the greater world of palliative care. Okay, everybody understand that? So hospice is an element in the much bigger universe of palliative care. The venues for palliative care include inpatient hospital settings, home, getting palliative care in the home, and we'll talk a little bit about Schenectady in that regard. We have an active program in Schenectady, and I'll show you some of our results, and I'll talk a little bit about how that works. And the hospice itself, as you know, can be delivered in home or in the hospital or potentially in the community as well. So the question that gurus always want to know is, how big is the need? And we talk about the silver tsunami that is coming in this country. I look around, I see some silver hair. Those of us who are of a certain age recognize the fact that between 8,000 and 10,000 Americans are turning 65 every single day in America. Every day. 8,000 to 10,000 Americans are turning 65. That's the wave front of the baby boomers, right? Now they're all retiring and they're going to have needs and so forth, and we'll talk about those in just a minute. But this is a profound demographic shift in America. Very, very big. I'm reminded of those of us who are in late 60s, 70s, what it was like to go to grammar school in the 50s. Sharing desks, overcrowded, right? So now it's, instead of being the classrooms overcrowded, it's going to be waiting rooms that'll be overcrowded, because we're shifting now from little kids trying to get primary grades to older adults as we age. These curves, I think, are very telling, and I just want to outline a couple of things here. If you look at the year 2020, which is right around the corner, you can see that there are going to be about 5 million Americans over 85. Oh, we just lost. What's that? He went to fix it? Okay, 5 million. I'll just keep going because I have these slides. 5 million Americans that are going to be over age 80. 5 million over 80, and at the same token, over age 65, it gets to be 50 or 60 million people are over age 65. So suddenly, there'll be Americans over age 65 equal to the population of Great Britain. Right? That's a way to think about it. And the population of people by 2030 who are over 85 will be equal to the population of New Jersey. So these are massive demographic shifts, and with those demographic shifts, is it coming back to life? I do too. I can assure you, and you all know this from thinking about your medicine cabinets, as we age, our need for health care and our need for healthcare services like prescription drugs and other kind of things continue to go up, right? Oh, this is a very pretty picture. So we know that our utilization of healthcare goes up and up and up as we age. So that is a very telling thing, especially for people who are running Medicare and Medicaid for the federal government. We know that demography drives demand, right? Because we need more care as we get older, total hips, total knees, shoulders. Oh, we're back. All right, next slide. So I'm going to move on. So this is the spending curve. So here we are by age groups, age cohorts, and you can see it begins to look like a hockey stick at about age 60, between 55 and over. And it really kind of plateaus at the end because the people who survive to 85 are, pretty well fit. Right? I mean, they are survivors, right? So they tend to have a flattened curve out here. This is the effort of the government to help us pay for health care. This is out-of-pocket expenses, which are relatively flat-ish, right? But the overall costs are very, very great. And so here was what I was going to try to describe for you, and that is that the demography drives the demand for healthcare, and the demand then drives the dollars. Okay, so I mean that's pretty logical. That'll make sense. So just to give you an idea of what some of these expenses are going to be like, and I know many of you are concerned about or have cared for or have an individual with dementia, Alzheimer's, or one of the other dementing illnesses in your family. Here's what we know. We know that in 2010, $215 billion was spent that year on people with dementia. What's interesting about that is that it was more than the combined costs of cancer and heart disease together. The other thing that we know about dementia, and those of you who have been caregivers in a dementia situation, is that there are hidden costs that never appear, right? The days that you could have been at work, so-called economists call it opportunity costs. So this is part of the cost, but it's a very, very big cost item. And look, by 2040, $375 billion. So a third of $1 trillion by the year 2040. Now you know why all those people are working in a frenzied pitch to try to develop drugs for dementia, medications and treatments for dementia. In addition, half of older individuals in the last month of life have a visit to the emergency department, 75% in the last 6 months of life. So that, just to translate that, you can assume that any visit to an emergency department is roughly $2,000. Okay, roughly $2,000. So when we think about that, we just do the math. 90% of ED visits for seniors are for symptoms, distress of one kind or another. And that's why when you hear about palliative care, outpatient palliative care, outpatient hospice, they emphasize this is a 24/7 coverage, so you can avoid sitting, or your loved one avoids sitting in a wheelchair in a waiting room hours and hours and hours while gunshot wounds and other things are taken care of in an emergency department. Oops, finally, let me go back here. And 50% increase of ICU admissions come from an emergency department. So if you can avoid the ED, you're more likely to avoid an intensive care unit, okay? Right? Because once you get into the system, as many of you know, things begin to happen. And we're going to talk about that at the end, how to maybe mitigate some of those longer-term risks. Now, what the Brits say is that 65% of those who die each year in the United Kingdom probably would benefit from some palliative care intervention. Now, I mean, that's a big, big number. But what it shows is their estimate is that the number of people who are getting palliative care is much larger than those who, the need is much larger than those who are actually getting palliative care. So big is this issue that the Institute of Medicine commissioned a report, Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. And this is a huge report. You can get it online, you can download it, you can read the highlights. I'm only going to summarize these 4 points. these 5 points, sorry. The emphasis being that what we really need is a person-centered, family-oriented care, which is, remember from the WHO definition, right? This is care for the family and care for the individual. Communication and advanced care planning, which we're going to talk about as we get to the end here. What are the elements of advanced care planning? Professional education and development. We know that for the population tsunami that's coming, we don't have near enough providers to do all that care. So we know that more of palliative care will need to be done in your primary care office, need to be done by nurse practitioners, physician's assistants, advanced practice nurses, others. So this burden, this lift will have to be done with a cast of individuals, teams of people to help us as we enter that part of that phase of our lives. Policies and payment systems, you'll hear. I'm going to talk a little bit about some of the weirdness that arises. Palliative care and hospice care in the heads of the healthcare planners in the 1970s, when hospice was built as a benefit for Medicare, were partitioned. There was very little palliative care per se in those years, but they wanted CMS, the Centers for Medicare and Medicaid Services, wanted to build a benefit that would help people who were no longer going to be involved with chemotherapy, radiation, medication for curative therapy, but simply to end their lives, okay? So strange things happened. We'll talk in a bit here about the fact that we now see this should be more like a continuum of care, rather than suddenly here's palliative care out here, and here's hospice here, and here's palliative care over there. It should be far more continuous. Public education and engagement, and I'll talk a little bit about public education engagement, but it's clear that we all need to be advocates for palliative care. We need to be advocates for expanding and improving hospice and end-of-life choices in death with dignity and physician medical aid in dying as well, of course. So a brief history, not a brief history of time, but a brief history of palliative care. I'll spare you cosmology today. Obviously, true caring goes way back into antiquity, when families cared for each other. In the Middle Ages, there were convents and hostels, hospitality inns, and in the city of Martigny in Switzerland, it's where the St. Bernard dogs were, right? And they had brothers, monasteries, and monks helped people get through the mountain passes that were on their journeys and pilgrimages, and they would put them up. And then also other religious orders took care of people who were dying. And then, as you can imagine, there were leprosaria, right, for people who were outcasts who needed caring. So this idea of compassionate caring has a long history, some of it formal, some of it informal. In the early years of medicine, when medicine began to get more scientific and more quote-unquote legitimate, symptoms management and comfort and bedside sitting began to be important, and then it was quickly overtaken when universities and medical schools were established, and the emphasis then became, rather than the compassionate side of healthcare, curing, microbiology, surgery, interventions, machines and imaging and all that stuff. So things did change. The modern hospice movement and really the modern palliative care movement really only dates to the 1970s. We think of this as, I guess, think of it as being far older, but it only really goes back to the 1970s, which is relatively recent, of course. And Dame Cecily Saunders, who was originally a social worker, became a physician, then became a professor in the United Kingdom, was the woman who really started it all. She started what we now consider hospice, both in the United Kingdom, and it quickly caught on the United States, Australia, the English-speaking world, and then everywhere in the world. So there's a huge amount. But she is the queen. She is really the presence, the eminence grise. She's now dead, but she was the leader in all of this, a very important figure. Hospice in the United States was initially started with volunteer teams, and then in 1982, the benefit for hospice was created, and with that benefit came money, and with money came personnel and people and training and so forth. So the evolution from in the 70s was slow. In 1980, it really began to grow, and I'm going to show you some graphic information in a bit how it continues to grow. Both palliative care and hospice care is growing very rapidly in this country. There is formal training now, board certification for physicians, for nurses, for social workers, clergy people. I was recently at a meeting where there were a group of clergymen who were involved in palliative care and hospice, and they were trying to decide how they measured the impact of their care so they could justify it to CMS, which is very interesting. I mean, you don't often hear ministers talk about that kind of stuff, but they were scratching their heads and having this discussion quite recently. So how do U.S. experts, how do the palliative care people we know, we interact with in our communities, how do they think about it? Well, they think about it as either a specialized or generalized area of care. So you might be seen by a family practitioner, you might be seen by a board-certified palliative care specialist. Both of those groups are engaged in patient care. The focus is on improving the quality of life as defined by the patient and the family, not as by some artificial definition. It's made up almost invariably of an interdisciplinary team. So when people are engaged in palliative care or in specialty area like hospice care, they invariably are cared for by a physician, social worker, aides, frequently nutritionists, clergy people, and others in a team that provide care that addresses the individual's needs, pain control for one thing, other kinds of suffering going on, and how the family is coping. Is there a need in this family for respite care? Does the family need a break? Should that happen? How are we doing caring for the family as well as caring for? So it's a comprehensive team-based care view for the entire constellation, family and patient together, and appropriate for any age, any life-limiting diagnosis, or serious life-threatening diagnosis. So in other words, it's not just cancer or not just end-stage heart disease. It's a variety of debilitating illnesses, and I will show you some examples of that in a bit. And so here's a commentary I really like. The tools of palliative care are defined by the goals of that care. The first goal is not curing, but healing. That's very important. And I can't tell you how different that is from the way many people are trained in formalized medicine. In formalized medicine, there is this sense of opposition, right? The illness is the enemy. We are going to beat that. We're going to work with the patient to give the right antibiotic, to do the right surgery, to offer the right chemotherapy, and so on and so forth. That's the drive toward cure. If you think about it carefully and you talk to palliative care specialists, their job is to help the patient and the family heal, work their way through the illness without necessarily worrying about the fact that we fixed this patient. It's not about fixing the patient. It's helping the patient cope. It's helping the patient do those important things that they need to do as their illness progresses. Okay? And everybody clear about that? That is a profound difference than what you ordinarily get when you go to a doctor's office. Right? And that is why this difference in healing and curing is part of the reason that I think it's been so difficult for physicians who are trained the way I was trained to get their head around what the goals really are for palliative care. Okay? No fault. We're not making any judgments. We're simply saying it's different. It's a different approach. And when you talk to palliative care docs, they get it. They understand that it is different. The goal is to relieve suffering. Next point, physical, emotional, spiritual distress, patient, family, professional communications. Very, very important. Making sure that I'm listening to you, you're listening to me, and we really are communicating about what your needs are, what your goals are. Very important, and think about what your usual encounter is like in curative care when you go to visit the doctor. Not a lot of time for back and forth. The visits are relatively brief. They are focused on one topic area. We kind of want to get in and get you back out again. I'm not, again, being critical. I know the pressure they're under, but I'm pointing out that this is a different approach. This is about, am I hearing you? Do I understand what you want? Do you understand how we're going to try to work together? It is a different model. And finally, coordinated, communicated, and continuity of care supporting for social and practical needs, not just antibiotic, not just the chemotherapy, not just this, not that, but the whole constellation. And this is such a relief. When families get this and it's done well, it is a profound relief to them because they are suffering too, right? You all know that. Those of you who have been caregivers, you know that families are suffering along with the patients. And talking about suffering, I have to tell you, and it was a while ago when I went to medical school, but the S word we never used. No. We never talked about suffering. We talked about patients with distress. We talked about patients with pain. We talked about symptoms. We talked about how to treat this or that ache or pain, but we really didn't talk about suffering. Pardon me. And suffering has multiple components. I think we all recognize that. There's physical, there's emotional, social, and spiritual. And one bolt out of the blue that came to me at a luncheon with a palliative care doc from Toronto about a month ago was, he said, the only other kind of suffering that we hear about here in America that is almost never talked about in Canada is financial suffering. And that, you could have knocked me out of my seat at that restaurant because I had not thought about that. But it's an element, and probably it's an element somewhere, maybe in the social aspect, that the worry about the money and so on and so forth that goes with it. So bad enough that somebody has a life-limiting illness, bad enough that they are having physical suffering, but to add to that, the worry about the money is unsettling, right? It's very unsettling. So the tools here, again, we've talked about this. Cure is healing, relief of suffering from any source is the daily work of the caregivers. Most powerful intervention is presence with compassion, and arguably the most difficult thing to do, right? To sit there. And you may not have any tools in your toolkit. All you really have is your presence to be there, to listen to that person, talk about what they want to talk about, making sure that their needs are being met, but more importantly, being there with them. I have a good friend, medical classmate, who has a very serious cancer, and I've been visiting with him. And it's interesting, we don't talk much about his tumor. We talk mostly about other things. Donald Trump, kind of whatever comes up. So, I don't know if he's suffering. I think he's not suffering, in fact, knowing this guy. So anyway, that idea of presence, physical presence, is really, really important. And this came to me, this understanding came to me really from the Buddhist monks who run hospice programs both in New York City and California. They talk about this. They talk about being focused and centered and being present with yourself, but most importantly, being present with the patient who's with you. So the question you may be asking is, okay, well, that sounds lovely, Dr. Pratt, but does this stuff work? Okay, does palliative care work? And there is an overwhelming amount of literature that will suggest it does work. And I'm going to talk a little bit about advanced care planning, and I'm going to talk a little bit about actual interventions run in parallel with chemotherapy, and then I'm going to talk a little bit about what happened in Schenectady when we ran a program for a calendar year as an outpatient. Okay, so let's begin by looking at this. Now, forgive me for all this kind of confusion in writing about research design, but just to say that this was randomized, and randomized controlled trials are the gold standard in healthcare research, and that is to say that they try to assign patients to two groups without any bias, okay? So if you're number 13, you go into group A. If you're number 12, you go into group B. And so they're randomized in that regard. So what happened here is that these are patients who are randomized, 309 elderly people, hospitalized patients who are over age 80, and they began to work with them on advanced care planning, them and their families as well. So 81% received the advanced care planning, 56 completed advanced directives. So advanced directives is, everybody know what an advanced directive is? Okay, good, great. So then what happened? So families were present in 72% of the sessions, and the sessions took roughly an hour to do. Seems in modern outpatient medicine that would be an eternity, right? But for these patients, you need it. So here's what they found. And let me just tell you that any number that is like 001, 02, anything like less than 0.05 is significant and important. Now, what they found was that here's anxiety was markedly decreased in people who had advanced care planning. Depression went down. PTSD can occur in caring for people who have life-limiting illness. It can. It impacts us emotionally in that way. Now, I'm a little concerned that all these zeros, because I know from medical research, almost never all zeros, right? So this may be a little better than in reality, but in the point of fact, I think what we learn here is that the satisfaction with the end of life among families was improved, and the satisfaction with the care was also improved. So it does appear that palliative care does add value to people and families if they have done advanced care planning. This is a chart, and I'll just quickly tell you, but this is a lung cancer study done at the Massachusetts General Hospital in Boston, and they found that people who had early palliative care actually lived longer than people who are equally, same kind of tumors, randomized to no palliative care. So people actually lived longer and did better who had palliative care along with their chemotherapy. And then finally, and pardon me again, this gets statistical, and that's because you have to send it to journals and they won't accept anything else. But here's what we found in Schenectady. We found that before people joined the program, they had on average in the prior year 1.46 admissions to the emergency room and 1.02 admissions to the inpatient facility at Ellis. And after the program, it went from 1.46 to 1.08, 1.02 to less than an admission. So what happened was people who were in 24/7 outpatient palliative care didn't need to go to the emergency department and didn't need to be admitted to the hospital. Both things that a lot of patients really don't like. They don't, they'd rather not do that or go there. So in local level, we showed that it does that, and simultaneously, and probably even more importantly, the experience of care was better, and the patient's quality of life was improved. So not only did we save money from the big pot of gold, we took some money out of that pot of gold, but we also gave people satisfaction and the 24-hour response on the phone. Now, palliative care programs are growing dramatically, almost trebled since the year 2000. Wow, that's spectacular growth, right? The benefit itself, and I'm going to talk about the benefit in terms of, what can we expect from the program, but first, the benefits of palliative care in the other term. So, honors the residents' wishes, right? The wishes for dignity, provides evidence-based measures for good symptoms management, demonstrates partnering and collaboration with the resident, family, staff, palliative care team, provides a common platform to discuss the goals of care and advanced directives. So those are all good things, right? So that's what the benefit really is about. Now we're going to talk about coverage. So now the coverage for palliative care, and this is where Bonnie and I had a sort of a lengthy discussion. The coverage for palliative care, most insurance plans do cover it in the inpatient facility when you're an inpatient. And most insurance companies, certainly Medicare, covers hospice care at home, right? Also, hospice care benefit does overlap into nursing homes and also potentially just in a hospice facility. Where it gets fuzzy is outpatient palliative care. Outpatient palliative care at this time is not really covered per se as a benefit by many of the insurance companies. The experience that we had in Schenectady was we offered palliative care on an outpatient basis through the visiting nurses. And if the patients had a skilled nursing need, and some of you will know that's the definition of getting care, they had a skilled need and they had a life-limiting illness, we offered them care choices, which was our outpatient palliative care program. And we went to the insurers in the capital region. And I remember here, I'm not speaking for MVP, I'm here speaking to you as me, okay? But we went to the insurers, including MVP, and we said, would you be willing to fund this activity? Because we think it's good. There's evidence from the literature, some I didn't show, that shows that overall patients do better. There's a total savings and so forth. And in the initial go around, they said, we're interested in your data, but we really don't. We're not going to fund it. So we went the first 2 years without payment from the insurers, and we collected data very carefully. And the data that I showed you from emergency department and from inpatient was what we brought to them. And now I'm pleased to say that all 3 of the major insurers in the capital region are beginning to pay for their patients to get outpatient palliative care. So it is growing. And I think as the insurance program grows for outpatient palliative care, we will see the number of providers grow and the number of programs grow simultaneously, right? Because it's the old Watergate paradigm, follow the money. Right? So if the money goes in the right direction, things begin to happen. I told you, this was established in 1982, because of the desire to provide better end-of-life quality care. The eligibility, people have to be enrolled in Medicare Part A. Many of you are enrolled, no doubt. Have to have a terminal illness that will last 6 months or less if it runs its natural course. And the individuals have to be willing to forego chemotherapy, radiation therapy, and basically give up the benefit, the prescription drug benefit for those agents if they go on to the hospice program. For many people, that's a very sobering prospect, but those are the rules. I'm just telling you the rules. The benefit period is 2 90-day benefit periods. Think about it. 2 90-day periods is 6 months, right? Benefit was built for 6 months or less. Has to be recertified by your doc, or the hospice doc can recertify, and it can go on. You can go off hospice and go back on. That's okay. That's possible to do. Let's see. And again, recertification. Yes.
Didn't you just say palliative care or hospice care along with chemotherapy? Was I wrong?
Let me state it again. What I said was, to qualify for the hospice benefit under the rules of Medicare, okay, you need to be, you must agree to forego curative care. That's the simplest way to put it. Curative care. That would be radiation, chemotherapy. Okay? For hospice, but not for, no. In palliative care, and thank you, Bonnie. In palliative care, concurrent curative therapy, absolutely okay. Absolutely okay. Yeah. And I can tell you, some people in our palliative care program in Schenectady go off palliative care. They improve. They don't need, they no longer need the team-based approach, so they can improve. And some of you probably know from your own experience that there are people who actually kind of graduate from hospice as well, right? So, I mean, this isn't, frequently people say, this is it, man, I'm done for. If I go on hospice, that's, I'm sort of hanging it up. And the answer is maybe, but maybe not. Some of these people actually do get better and have improvements and go off hospice and ultimately may need to go back on again. Yes, Nancy?
Are antibiotics considered curative?
No. Antibiotics are okay, and they're covered under the standard Part D if you have Part D. Medicare Part D. Okay. Medicare Advantage, people say, "Ooh, I don't have, regular Medicare. What about Medicare Advantage?" In Medicare Advantage, you still can get hospice care, but it has to be done under the traditional element of Medicare. So it's a little bit funky, and that's got to improve, and I'm going to talk about hope as we go on, that may very well improve.
Isn't it one of the requirements for hospice admission is that two physicians have
Yes, indeed.
5
Two physicians
Person
agree.
will live only 6 months or something?
Exactly. Two physicians have to agree that your life expectancy is 6 months or less. Yeah, that is true. Yep. The reimbursement currently works in this fashion. Make sure you got this. Routine hospital care, inpatient care, continuous care, respite care, which is very important for families and others, right, to get respite care, and is not currently adjusted for case mix, which means for cases that are more intense. It's sort of a vanilla flavor, one size fits all, right, and without intensity, because think about it, at the end of life, it's likely that the intensity for hospice care would be greater, therefore there would be more person hours needed, so it would be smarter from a business vantage point if at the end of life we paid more for the caregivers, right? Wouldn't that make sense? As opposed to a standard band. You're going to hear that, in fact, we're beginning to move in those directions. And there are some caps. There's a total cap for some of the payments in aggregate. Here's what I was talking about. We know at the beginning of when you enroll there, things may be, it takes some energy and time to enroll people, and then as they approach the end of their life, the intensity of what they need goes up, 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 right? So there's got to be a better way to do this. And in fact, there has been. Changes have been made. And I'll talk about that in a little bit. This is just a way of thinking about how we process the ideas of caring for people with life-limiting illness. This is the way it's always been. Curative care, and you get to this point and you got 6 months left to live. You get hospice care, which was, remember we said, is part of palliative care. Boom. Okay, here I go. Boom. Now I need hospice, right? A much more prudent, a much wiser, a much more empathetic and understanding is this. You get a diagnosis that's a life-limiting illness, and you begin to talk to people in palliative care, and you move along this continuum until you get to a point where you do have 6 months or less to live, and then you can invoke your benefit under hospice, right? So I've made this look like it's, I've left out hospice, not intentionally, but only to emphasize the fact that you really need to start way back here. And one of the reasons you need to start way back here is because that's the point at which you need to have that conversation with your family as well, right? We need to do that planning, important planning, talking about what we want at the end of our lives, electing and finding out who's going to be our healthcare proxy and so on and so forth. At this point, I always tell a little story, a Yogi Berra story, which I like. And it has to, Yogi Berra, American philosopher, right? If you come to a fork in the road, take it, that guy? Right, okay. He said, I never make predictions, especially if it involves the future. Well, he said, and this involves his wife, Carmen, and Carmen was talking with Yogi, and she said, Yogi, you're reaching the end of your life here, and, we've done some wonderful things and so forth. And she said, you had a lot of fans, wonderful career, Hall of Fame, blah, 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 on and on. And she said, but my question for you is, Yogi, when you die, where would you like to be buried? Would you like to be buried in Brooklyn? Would you like to be buried in New Jersey? Or maybe St. Louis, Missouri? And Yogi said, I don't know, Carm, surprise me. And as we know, surprise is not a plan, right? It's like hope is not a plan. So doing these things, planning ahead, down here, folks, not up there. Down here. And we'll talk about some of the detail and what kind of planning people really need to do as they progress in their illnesses. But in addition to the medical, legal stuff, there's also emotional stuff that really needs to take place. Some people's lives, they need to make amends. At times we need to ask forgiveness. At times we need to forgive people in our lives, right? And sort of knit up the ravel sleeve of life, at that point. And that's important work. It needs to be done. And we always think, well, my goodness, I'm just going to die and sort of go off. In fact, there's a lot of work in it, and to have a good death requires a fair amount of attention and paying, doing planning and doing important things in time. So, persisting problems with the hospice benefit. No question that there are. Yes, ma'am. Sorry.
Before we move on from that last slide, how do the aggregate caps for reimbursement affect those models of care?
Yeah, that I cannot answer. I mean, anytime there's a cap, it only means that the benefit ends. It doesn't mean the care ends, right? But then somebody else is on the hook. right? So there's a lifetime limit, if you will, and you may have other other insurance where there's a lifetime limit. That's what it means. It's an aggregate total. And somebody here may be an expert on the benefit and could address that, but all I know is that you bump into a limit.
On Medicare?
Yeah, under the hospice benefit, there is some limit. Yeah. Okay, which means you can't go on and off hospice 20 times, right? In reality, there are persisting issues with hospice and the eligibility standards. And here the eligibility standards, part of that is if I want to continue with chemotherapy, if I want to continue with radiation, the answer is currently no. No. You don't. It would make you ineligible. So there's that issue. Number two, it would be better if Medicare Advantage had it built in. You didn't have to go back to the other benefit to take advantage of it if you're a recipient of Medicare Advantage. So it probably needs to be baked in rather than put aside. And nursing home residents, the people who run nursing homes say that it's cumbersome. Doing hospice well in nursing homes needs a lot of work. So yes, it does need a lot of work. How am I doing? Okay. So some of the trends that I want to just share with you is that, like palliative care, hospice, the number of hospice programs is growing. It's about a 20% change from 2010 to 14. So that's a very nice change. We also see here that the conditions, and this may interest you, and it was surprising to me when we began to collect information on who we treated in Schenectady, but the bulk of the people getting palliative care do not have cancer. They do not have cancer. So it's interesting that a third of the patients roughly have cancer, and non-cancer diagnoses go down like this. We were very interested to learn that two of the very big groups we have in Schenectady are people with end-stage heart disease and end-stage lung disease. So it's not just about cancer. Some of us think it is. Certainly dementia is going to be coming up, in the future, and other neurologic diseases will be coming up as well. Here's a slide that's a little disconcerting. And if you look at it, over here are the number of days people are on the hospice program. You can see more than 50% of people wind up on hospice for only 2 weeks. And that's not enough. That's frankly not enough. Much more caring could be done prior to that. I don't know what the magic number is. I really don't know what that magic number is, but it's not 2 weeks. It's not a week, it's not 3 days, right? It's probably something more like 6 weeks, 2 months, like that, to really be able to take the full advantage. So this is a little disconcerting. We can do better than this. And what's another interesting trend is it's becoming much more private, okay? These are the for-profit organizations that are running hospice programs, and these are the not-for-profits. So you can see the trend has clearly been for people, for-profits, to get into this business. So someone's making a buck, for sure, right? This goes to show you who the current payers are. No surprise here. It's mostly Medicare, right? Managed care, private insurance, and Medicaid to some degree. Now, I can tell you just one good thing about the state of New York. We're doing more and more and more Medicaid. We're going to see more palliative care being offered to Medicaid patients as well. Here's United States, a number of programs. You can see poor little New York is here. We could use a few more programs. Pennsylvania here, the ones that are deep and out of the thing are better programs, more of them. Yes, sir?
The previous slide, could you go back to that?
Can I go back to that? Yeah, there you go.
Does the VA play a role here at all?
The VA has a very good programs, actually.
And how does that compare?
I don't know where it fits in here. It's certainly not under, it's not under the Medicare benefit per se, although I don't know. I mean, Champus, and the VA benefit is unique. I'm not sure how that all goes. I just can't, I don't know those answers. Sorry. Okay, so moving right along. So individual's responsibility. This is where you come in to this equation. So number one is items that you probably will want to have. A living will, right, has power in the state of New York. Durable power of attorney. Durable power of attorney is that legal document, and some of you came to the attorney's talk here, which was excellent a few weeks ago. Durable power of attorney is a document that you sign that gives somebody else the power to act for you if you lose capacity. Pay your cable bill, write a check to a vendor, do that kind of thing, and you're in the hospital, you really can't do that. Physicians' orders for life-sustaining therapy or treatments, we call that MOLST here in New York. It's a medical order that limits the kind of interventions you want should you become critically ill. Communications with your family, with your loved ones, vitally important. And this website, the Conversation Project, coaches families about how to have that conversation. This is hard. This is a hard conversation to have. Ellen Goodman, the writer, columnist, newspaper lady, had a real issue with her mom. She decided that she needed to do something. She really put this all together. Wonderful contribution. So you can advance directives, talking about healthcare proxies. Who would you like to speak for you if you, again, are no longer mentally capable to speak for yourself? Who would be that right person? And I've had people say to me, well, it's not my son, it's got to be my daughter. My son has crazy ideas, but my daughter's, bingo, right on the money, right? I mean, we all know that. So it's a good thing for raising discussion. Specific treatments you do and do not want. Next of kin to make decisions for you, and that's your proxy. And I'll tell you, if you get a proxy and you're ill, that proxy, if they can go to your doctor visits, would be a great idea. That'd be a great idea, right? And the advance directives really can ease the burden on your family. Many, many times when I was practicing pulmonary medicine, we'd have a family meeting, and the cousin from San Diego and the lady from Phoenix would sit down and not agree with anybody from Herkimer or local, so the family would not agree what's going to happen with the patient. Not a good idea. If you have advance directives and it's clear what you do and do not want, no more of these family tiffs and dust-ups around the end of your life. So, a discussion, this is pretty straightforward. You want to have the right people in the room, especially your proxy. You want to bring appropriate documents and have the documents available. And think about the things you do and do not want. Do you want to have CPR? Do you want to go on a ventilator? Do you want to have a feeding tube? Do you want to have this? Do you want to have that? All these things are worthy of your careful consideration. Discussion of the issue of dying, as Woody Allen said, not easy, right? But it's one of those discussions that we really need to have. The next slide is very important in terms of counseling physicians. It's very important for nurses, doctors, social workers, clergy people who are in the palliative care team to listen to the patient, to encourage questions from the patient and from the family. And by the way, one of the key things I've learned about that is you really need to ask permission to have this conversation. Because not everybody's really ready. Some people are never ready for this conversation because their denial is their defense mechanism. And when we strip that denial away, it's not good. It's not good. So I think one needs to make sure that we both agree, doctor and patient, we're going to have this conversation, okay? And then you may get to a point in that conversation where it's a bit overwhelming. Let's continue this at the next time we sit, and we can go from here. Okay, because I had a professor who once talked about being assaulted with your diagnosis. We don't want that. No assault by diagnosis. Sensitive again when you're ready, willing to talk. Right. Okay, so my thanks go to mentors, people who've contributed, done wonderful things. Dr. Curtis, Dr. Meyer, Phil DeSorbo, who started community hospice here in this area, a brilliant guy, a great guy. Dr. Jokas, who's a colleague and friend of mine in Schenectady, who's done wonderful work with community hospice and the inpatient setting at Ellis Hospital, and the Center to Advance Palliative Care. And Dr. Meyer. Dr. Meyer is currently the director of that center. So I am now finished, yes. And I've maybe got a minute left. Sorry, I kind of went fast, but thank you.